Thank you for joining us. I'm pleased to introduce Dr. Lara Best. She is a radiation oncologist at the Nova Scotia Cancer Centre and an associate professor and program director of the residency program at Dalhousie University. Her practice focus is skin, head and neck, and CNS tumors, and she is an avid user of 3D Bolus. Today, she is going to talk about her current practice, including why and when she uses 3D Bolus, as well as some recent patient cases to highlight these benefits. So welcome, Dr. Best. I'll hand it over to you.
Oh, thank you. Thank you for having me again. I put together just a short presentation just to highlight my journey through 3D Bolus and where I use it. So I think you've already mentioned most of these, but for anybody who hasn't met me, I am board certified radiation oncologist with licenses here in Canada as well as Australia and New Zealand. I've completed 2 fellowships and I'm currently practicing here in Halifax. And one of my main areas of interest is skin cancer, which I have been treating for over 10 years. And after practicing for 2.5 years in Australia, I definitely saw a lot of skin cancer with some patients presenting with over 200 skin cancers. And one of the things that I noticed when I started my practice is the difficulty of getting good skin apposition and bolus, especially for areas of cancer that were on irregular surfaces. So thinking about ears and nose and the limitations of conventional bolus such as superflab or vinyl sheet bolus. And you can see some examples where it can be a little bit challenging to bolus these. So this is where, 3D bolus really helped me out a lot. Well, I have just a couple of cases to highlight kind of how I adopted 3D bolus. And one of the main areas is making sure we get good skin apposition for irregular surfaces or filling in gaps due to tissue deficits. One of the first cases that I treated was a gentleman with an ear cancer. It was going into the external auditory canal. He didn't want surgery. And these are the type of cases prior to 3D bolus, you'd have a piece of superflap behind the ear and over the ear, and then you'd have to make a plug for the conchal bowl. So there's 3 different pieces of bolus. So getting reproducible setup was really difficult. So we tried 3D printed bolus, and because it's based on CT anatomical data, we were able to get one piece of bolus that you can see almost clicks in around the patient's ear. So you get that post-auricular coverage into the conchal bowl all in one go. So it's much easier for setup. And there's been some research done around that as well, which shows that using 3D printed bolus, especially in cases like ears or large contour changes, you have less air gaps, especially the 5 millimeters, which is dosimetrically important. And you get better dose coverage and dose deposition accuracy. And with these, because it's one and it kind of clicks into the patient, your setup time on the linear accelerator can actually decrease by almost 30% as well because of that accuracy and reproducibility. So your throughput through your machines can actually improve as well. There was an in-house study that we did as well looking at patient satisfaction, and most of the patients found it quite comfortable to use and really liked that it was a lot easier and decreased their treatment time. And that was looking specifically at the soft silicone bolus like you see on this patient here. Another case that I had recently that really showcases where 3D bolus can be helpful is a lady who was elderly who had cutaneous squamous cell carcinoma mets to her breast. And this one was challenging because we needed to treat her breast. It was quite pendulous, so her breast was quite mobile. So the concern was making sure that we had a consistent setup with a breast that was quite mobile. So this is where using bolus as both an immobilizer as well as bolus was quite helpful. And we tried 2 types of bolus. So the soft silicone, which you can see on the far right, as well as a more rigid bolus. And we found the rigid bolus was slightly better in this case because it allowed for support of the breast, so we have consistency of the location of the breast while also providing bolus. So again, this is another area where it can also decrease your staff and material cost and time, because prior to trying to use bolus here, we tried water-soaked abdo pads, but they were just ending up on the floor and it wasn't consistent. So it can actually help with fabrication time. Robar also, in some of the initial studies on 3D bolus, shows that when you are using the bolus, you can actually leave little pockets for dosimeters such as MOSFETs as well if you want to be able to verify your dose deposition. The other area that I have implemented 3D bolus is actually using brachytherapy. And I had an elderly gentleman who had a quite significant movement disorder. So that precluded him from linear accelerator-based treatment. So he would be a candidate for brachytherapy, and he needed treatment because he wasn't a surgical candidate. And he had these growing lesions on his thighs. So we actually treated this with brachytherapy, but used a 3D printed bolus to create the bolus with the appropriate tracks, which could be done in the 3D bolus software. So you can see that here on the right. And he actually had a complete response to radiation therapy. Also, because this bolus was specific to his anatomy, it was quite easy to place on him every day, and we're able to treat him in a wheelchair. We presented this in 2020 at the AAPM conference. So just like any other technology, whether you're looking at stereotactic radiation, brachytherapy, or 3D bolus, it's not perfect for every situation, and you have to consider a few other things as well when you do introduce this to your practice. So one of the areas is for large fungating lesions. So you can see 3 here that I have treated in my practice. So if you have a patient who has a rapidly growing tumor, you want to get them started within 24 hours, you might have to start them with conventional bolus, as the fabrication time for 3D printed bolus can take a couple of days. Likewise, if you have a rapidly growing tumor, it might rapidly decrease. So you also have to consider replans and what you're going to do to hold over for that as well. The other thing with soft silicone bolus, it can be quite comfy even when it doesn't fit. So when you are using the soft silicone bolus or any bolus, you should be verifying placement with onboard imaging. So you can see here on the left image that ear patient that I showed earlier, the posterior pinna portion of the bolus was not actually fitting, but the patient thought it was. So this is where cone beam CT can be really important in those cases. So as a summary as to when I use 3D bolus, so I use it every time that I treat something that has quite significant irregularity of the skin surface. So thinking about ears, nose, if you're looking at the hand, especially if you're getting into digits, if you have a large area such as a subtotal scalp, but there's a lot of contour change. I also often use it for those where I need a combination of immobilization as well as bolus. So thinking about the chest wall, the breast, like the case I showed you, or for extremity brachytherapy. The areas where you might not need 3D bolus, if you have an area that you're treating that is both small and flat. So thinking about the cheek or the back where there's not a lot of contour change. And then there's always those cases where you want to have a talk with your planners and physics as to the appropriateness or how to implement 3D bolus. So again, those fast turnaround times, and do you need a hybrid plan with conventional bolus and then 3D bolus once it becomes available, if something's large and fungating, or you think there's going to be a large change in contour during treatment, and maybe planning around how you're going to manage that. So 3D bolus, I think it has revolutionized the use of bolus within radiation oncology, but I don't think we've seen the full benefit yet. So one of the things on my wish list is looking for ways to combine both immobilization and bolus in a way to index that to the table. So especially for patients that are in a non-standard setup. So this patient obviously can't be treated supine with a thermoplastic mask, but being able to index him either lying on his side or prone with good immobilization to help decrease that treatment volume or your PTV margins, I think would be really beneficial in the future if you're thinking about treating places like the inner arm as well. So that's a short stint on what I'm all about and how I have implemented 3D bolus in my practice. Here's just a list of a couple of those trials that I had mentioned earlier. I'll stop sharing.
That's great. Thank you so much. That was really insightful. I do have a couple of questions, and I'm sure Gosha does as well. And my first question is, when is the decision made to use 3D bolus, and how is that flagged in the workflow for you?
Right, so I usually make that decision at time of first consultation. So when the patient comes in, I have a look at where the tumor is, the size of it, do I think it's appropriate? And I flag it right at that point. So when I'm ordering the radiation or requesting the radiation, we actually have a tick box in our request for radiation saying, yes, I think this is going to be a 3D bolus, just so they know that to initiate that extra pathway.
And I'd imagine care paths associated with that as well.
Yes.
Yeah. And you mentioned in one of your slides that there's those phone a friend situations where you're not really sure. I'd imagine there's a lot of conversations with dosimetry, and maybe some of those are a little bit back and forth, and then the decision may be at the in the planning stage. Is that appropriate to say?
Yes, very appropriate. So when I can, if I think it's a borderline case, I'll try and call them up at consultation for either physics or dosimetry to attend. Or if it comes up at the time of CT sim, so that breast lady that I presented, we actually called both physics and dosimetry to come at that point. Occasionally, yes, it has come up at the planning process as well. And I think that's where just maintaining a good communication is really helpful.
My second question is about imaging. So you mentioned that you had a daily cone beam CT protocol for that ear, I think it was the ear patient. Yes. Is that typical for 3D bolus patients for you to have a daily imaging check?
Yes, most of our 3D bolus patients go through with VMAT treatment, and our standard of care for all VMAT patients is cone beam CT.
I have a couple more questions. Thank you for this really interesting presentation. My first question is, how do you envision the role of silicone boluses evolving in radiation therapy practice in the future?
I like silicone bolus because it's very similar to conventional bolus such as superflab or vinyl. So it's got the same sort of consistency and movement, but it allows you to conform it to the patient. So I see silicone bolus as almost replacing things like superflab in the future, especially when you don't have a flat surface. So for me, it's kind of my first choice unless I need immobilization at the same time.
Okay. And how do patients typically respond to the use of silicone boluses in terms of comfort? How do they tolerate those boluses?
So as part of one of the trials that we did in-house, we did collect some qualitative data. We didn't publish it, but the majority of them actually preferred the silicone bolus just because it took less time to put on than if you're using multiple different pieces of superflab because it was specific for their anatomy. And they found it quite comfortable, especially as they're going on through treatment where they were getting edema at that site. So overall, it was positive.
Thank you.
Any other questions, Gosha?
No, that is all. Like, presentation was fantastic.
Well, thank you so much. We get a lot of questions about this with our customers and potential customers. So we really appreciate sharing your insight and how you currently use 3D bolus. So thank you so much.
Yeah, my pleasure. Thank you.